Very good morning, everyone. So today we'll be starting our glaucoma seminar. So the first speaker, you can start your seminar on anatomy and aqueous humor dynamics. Please share your screen.
Yes, ma'am. Am I audible, ma'am?
Yeah, please speak louder.
Good morning, sir. Good morning, everyone. I'm Sujata, and today I'll be talking about anatomy of angular anterior chamber and aqueous humor dynamics. First, anterior chamber is an angular space formed anteriorly by the posterior surface of cornea and posteriorly by the lens within the pupillary aperture, root of iris, and a part of ciliary body. This is the angular structure, the anterior chamber, lying anteriorly by the posterior surface of corneal epithelium and posteriorly by the root of iris, lens, and a part of ciliary body. The depth of the anterior chamber in the center is 3 mm and it holds about 0.25 mm of aqueous humor. The angle plays an important role in the drainage of aqueous humor. It is formed by the following structures from anterior to posterior. And anteriormost, the Schwalbe's line, trabecular meshwork, scleral spur, and the anterior ciliary band. The structures can be visualized by gonoscopy. There's something called Schaffer's gonoscopy grading based on the width of the angle of anterior chamber. Grade 4, 3, 2, 1, and 0. Grade 4 is angle with 35 to 45 degrees, which is normal width. The angle is wide open and chances of closure are many. The structures visible are Schwalbe's line to ciliary body. All the four structures are visible. And grade 3, 25 to 35 degrees. Chances of closure are many. And structures visible are Schwalbe's line to scleral spur. Ciliary body is not visible. And grade 2, angle width is 20 degrees, moderately narrow. There's a slight chance of closure. The structures visible are Schwalbe's line and trabecular meshwork. And in grade 1, the angle is further decreased, 10 degrees, and there are high chances of closure. The structure that is only visible is Schwalbe's line. And grade 0, angle width is 0 degrees, it's completely closed, so there are no structures that are visible. Then coming to Schwalbe's line, this marks the anterior border of the angle and represents the termination of Westmann's membrane of cornea. On gonoscopy, it is seen as a glistening white layer. So the Schwalbe's line, it marks the transition from trabecular to corneal epithelium. It also marks the termination of Westmann's membrane of cornea and insertion of trabecular meshwork into corneal stomach. The trabecular meshwork is a sieve-like structure made up of connective tissue lined by trabecular cells which have contractile and phagocytic properties. So there are morphologically and functionally, it is divided into 3 layers. The innermost being the uveal meshwork, the middle one being the corneoscleral meshwork, and the outer one being juxtapenetracular meshwork. The uveal meshwork is the innermost part. Trabecular bands run in radial fashion. The aperture size is 25 to 75 microns, larger apertures. And the middle layer is the corneoscleral meshwork, which is it's composed of larger cells. And the connective tissue sheets are arranged in laminar pattern. As we can see, they are arranged in layers, and the aperture size is 5 to 50 microns. And the outermost one is juxtacanalicular meshwork. It is like a cribriform meshwork. It lies adjacent to the inner wall of lens canal. And aperture size is very small. It's only up to 10 microns. And brown substance is rich in glycosaminoglycans and glycoproteins. So here we can see. The innermost one is uveal meshwork, middle one being the corneoscleral meshwork, and this is the juxtacanalicula measure lying
Sujata?
on the inner surface of squamous skin. Yes, ma'am.
Sujata, can you be a bit louder?
Yes, ma'am.
Yeah. Continue.
Next is the scleral spur. It's a wedge-shaped ridge. It is pale, translucent, and it's a narrow strip of scleral tissue. It lies posterior to the trabecular muscle. This wedge-shaped part is the scleral spur. It is attached anteriorly to the cornoscleral muscle and posteriorly to the ciliary muscle. So whenever ciliary muscle contracts, the scleral spur opens the trabecular spaces, and it also prevents the Schlemm's canal to collapse. So that is the importance of scleral spur. And ciliary body band, it is the posteriormost part of the angle. It represents the anterior face of ciliary body between its attachment to scleral spur and insertion of iris. So this is the ciliary muscle and its anteriormost part is the ciliary body band. What is the importance of angle of anterior chamber? It is very important for the classification of glaucoma, as we have seen the Sharp's theory. It helps us to classify and to know the extent of neovascularization. To assess the angle recession, it indicates any history of inflammation, any evidence of neoplastic activity, any degenerative or developmental anomalies, and for planning treatment in case of iris neovascularization and laser procedures. Now coming to aqueous humor dynamics. Aqueous humor is a clear, colorless watery solution. It is formed in the ciliary body, the pars placata part, and it flows from posterior chamber to the anterior chamber. In a healthy eye, the flow of aqueous humor against resistance it generates 15 mm of head pressure. So the functions are it maintains a proper intraocular pressure, metabolic and nutritional role, it provides nutrients to the avascular parts, cornea and lens. Optical function, it maintains transparency. It also clears the cellular debris and any infectious material. And the ascorbate content present in aqueous humor, it is an antioxidant and it provides protection against UV rays. It also facilitates neural response. It is mostly composed of water, 99.9% water and 0.1% solids. The protein content of aqueous humor is much less than plasma, and it's very high in ascorbate content. The refractive index is 1.336. So why pressure is needed? It's needed to maintain the shape of the eyeball, and it's also required to carry out the functions to maintain the integrity of the eye. The pressure is also required for the circulation of blood to the eye, and hypotonia is also dangerous because it can lead to phthisis valva due to retinal detachment. So now we'll see the structures involved in aqueous humor formation. They are the ciliary body, posterior chamber, anterior chamber, angle of anterior chamber, and the aqueous outflow system. For ciliary body, it consists of two parts, pars plana and pars placata. It's the pars plana, pars placata. Pars placata, it has finger-like projections that are called ciliary process that are 70 to 80 in number, 2 mm width and 5 mm length. The stroma is composed of network of capillaries and there's inner pigmented epithelium and an outer non-pigmented epithelium. So then posterior chamber and anterior chamber. Anterior chamber, as we have seen, it's between the posterior surface of cornea and in front of iris, and posterior chamber is behind the iris and in front of the lens. So anterior chamber 0.25 ml and posterior chamber volume is 0.06 ml. So total this 0.31 ml of aqueous humor. Aqueous humor formation, it's a complex process. Ciliary process of the pars placata, as we have seen, are the site of production. And there are mainly three mechanisms: ultrafiltration, active transport, and diffusion. Ultrafiltration, capillary blood flow, as we have seen in the schema, it is 150 ml per minute, and it's favored by hydrostatic pressure difference between capillary and the interstitial pressure. This ultrafiltration, it is enough to move the fluid to the stroma, but further movement requires active transport. So in case of active transport, it is an energy dependent process and it uses ATP. Sodium, 70% of sodium is actively transported by specific sodium potassium secretory pump. The transport of chloride is dependent on sodium and bicarbonate also follows. So here there is a concentration gradient and so the water also follows. So as the active transport leads to the formation of osmotic and electrical gradient, water and small plasma constituents also moves into posterior chamber by diffusion. So now that aqueous humor is formed and it's moved into the posterior chamber, it goes into the anterior chamber, it circulates. And from there, the outflow system is of two types, trabecular outflow and avascular outflow. Trabecular outflow is the conventional type. It constitutes of about 90% of the outflow and it's pressure dependent. So from the trabecular meshwork into the Schlemm's canal, trabecular meshwork into the Schlemm's canal, and then into the episcleral veins and conjunctival veins, and finally draining into the tabenosine. Then the avascular outflow, which is unconventional, 10 to 25% of the fluid is drained by this mechanism and it's pressure independent. From the ciliary body, the fluid moves into suprachoroidal space and then into choroidal vascularization and then sclera and then choroid, and then it moves into the orbital tissue. Now the Schlemm's canal, it is an endothelium lined oval channel present in the scleral sulcus. Inner walls are irregular, spindle-shaped cells, and they contain joint pathways. As we can see here, this is the inner wall of Schlemm's canal. Irregular cells, spindle-shaped, and they contain giant pathways. And the outer wall is lined with smooth flat cells, and they contain openings of the collector channels. Collector channels are intrascleral aqueous veins, aqueous vessels. They do not transport blood; they only transport the aqueous humor, so they are called the aqueous vessels. They lead the Schlemm's canal at oblique angles and terminate into the episcleral veins in a laminated fashion. So there are two systems, direct and indirect. Direct system, larger vessels, they terminate directly into the episcleral veins, and indirect, the collector channels form a plexus, and then this plexus drains into the episcleral veins. Episcleral veins, they drain ultimately into the cavernous sinus, while the anterior ciliary and superior ophthalmic veins. There is something called blood aqueous barrier. As we have seen in the non-pigmented epithelium of the ciliary body, the apical parts of non-pigmented epithelium may contain tight junctions. This forms the blood aqueous barrier, and this is responsible for maintaining the difference in chemical composition between aqueous humor and plasma. Maintenance of IOP. IOP is the pressure exerted by the intraocular fluids on the ports of the eyeball. Normal intraocular pressure is 10 to 20 millimeters of Hg, the average being 15 mm. It is maintained by equilibrium between formation and the outflow of the aqueous humor. There are some factors affecting the intraocular pressure. Local factors like rate of aqueous formation, which is dependent on the permeability of the capillaries and the osmotic pressure. And resistance to aqueous outflow, resistance is mostly at the level of trabecular meshwork. It can be affected by the increased episcleral venous pressure. Dilatation of pupil in patients with narrow angle, it leads to relative obstruction. And refractive errors, myopic individuals have a higher IOP compared to emmetropes and hypermetropes. So general factors like heredity, age-related, mean IOP increases up to the age of 40. It is usually equal in both the sexes, but above the age of 40, the rise with age is greater in females. So there are also diurnal variations. The pressure is higher in the morning and lower towards evening. This can be input to plasma cortisol levels. Postural variations, it increases with changing from sitting to supine position. Seasonal variations, pressure is higher in winter. Blood pressure is marginally, IOP is marginally more in hypertensives. It also depends on osmotic pressure. It increases when there is decrease in the osmotic pressure, like in case of drinking water for prophylaxis tests. And there is a fall in IOP when osmotic pressure is increased with the use of IV manifold and oral blood. And general anesthesia and exercise also they also affect the formation or maintenance of intraocular pressure. Thank you.
Grading.
Sharpness grade అని చెప్పండి. Sharpness grade చూపించండి.
Case of technical damage. Okay, thank you. You have done well.
So, thank you, sir.
Next. Next speaker.
అది Ashwini Dutt.
Ma'am, yes, ma'am.
Yeah, you will be speaking next, right?
Yes.
Thank you.
Am I audible, ma'am?
Can you be louder?
Ma'am?
Can you be little more
Yes,
louder?
ma'am. Am I audible, ma'am?
Yeah, now you're audible. Please start your presentation.
Yes, ma'am. Good morning, all. Today I am here to present about the glaucoma, the classification of glaucoma, and the congenital glaucoma. Now, first, glaucoma. It is a group of disorders characterized by the progressive optic neuropathy, which are resulting in the characteristic appearance of optic disc and the specific pattern of visual field defects, and it may be associated with the raised intraocular pressure or may not. Here in the first one, everything is normal, the optic disc is normal, and the visual field is normal, the intraocular pressure is normal, so everything is normal. But in the second case, the optic disc and the visual field are normal, but the intraocular pressure is raised. Even though intraocular pressure is raised, we cannot call it as glaucoma because the optic disc and the visual field are normal. It is ocular hypertension. In the fourth case, the optic disc changes are present and the visual field defects are also present, but the intraocular pressure is normal. Even though the intraocular pressure is normal, we can call it as a glaucoma, which is the normal tension glaucoma. In the third case, the optic disc changes are present and the visual field defects are present and the intraocular pressure is raised. It is a glaucoma with intraocular pressure raised. The pathogenesis. The progressive optic neuropathy is a result of death of retinal ganglion cells. The retinal ganglion cells death is due to the blockage of transport of the growth factors from the brain to the retinal ganglion cells. This leads to the retinal ganglion cells loses their ability to maintain its normal function and undergo apoptosis, and it also triggers the adjacent cells to undergo apoptosis. Of course, the retinal ganglion cells death is associated with the loss of retinal nerve fibers, which are leading to the characteristic optic disc changes and the visual field defects. The etiological factors, which are primary factors and the secondary factors. The primary factors include the raised intraocular pressure. The raised intraocular pressure causes the stress on lamina cribra, leading to the axonal deformation and thereby altering the capillary blood flow, resulting in the blockage of neurotropins to the retinal ganglion cells. And the retina and the optic nerve have a peculiar mechanism of autoregulatory mechanism of blood flow in this, which fails, resulting in the one of the cause for retinal ganglion death cell. And the vasospasm, which is affecting the vascular perfusion of optic nerve, and the systemic hypotension, which has been implicated for low vascular perfusion of optic nerve, leading to the neuronal degeneration. And, and the secondary factors include the glutamate, the oxygen free radicals, and the nitric oxide, which are released when the retinal ganglion cells death occurs due to the primary factors. Now, the classification of glaucoma is mainly into the congenital glaucoma, the open angle glaucoma, angle closure glaucoma, and the secondary glaucomas. The open angle glaucoma, which is the primary open angle glaucoma, and the secondary open angle glaucoma. In the primary open angle glaucoma, the angle is normal, anterior chamber angle is open, and the optic disc changes are present and the visual field defects are present. There is a slow progressive raised intraocular pressure. The problem is which there is a decreased aqueous increased aqueous secretion. The optic disc changes include the cupping of optic disc cup, and the cup by disc ratio increases. Eventually, optic atrophy occurs, and the nasalization of vessels occurs, and the laminar dot sign is seen where the ports of lamina cribrosa are seen, and the boneting sign is seen, the sharp angulation of the vessels, and the visual field defects. The earliest visual field defects, the isoptic function, the isoptic is a curve joining the areas of same retinal sensitivity. Due to the death of ganglion cells, the retinal sensitivity reduces, so the isopter contracts. And there is a progression of visual field defects of glaucoma in the primary open angle glaucoma, where initially we will see paracentral scotoma superiorly as the inferior ganglion cells die first, and eventually cedal shaped scotoma will be seen due to more ganglion cells death, and then arcuate scotoma, and then the ring scotoma as the superior ganglion cells also die. And ma'am, ma'am, is it visible?
It's visible. Please continue.
And there is a small peripheral temporal design period because peripheral nasal fibers are strong resistant. So the temporal side is peripheral. And in the single open angle glaucoma, because of the different mechanism of intraocular pressure increase, there is a pretrabecular membrane where it covers the trabecular meshwork, and in that there is a neovascular glaucoma. We have three stages. The first is the precomatous, and the second it is an open angle glaucoma due to the formation of trabecular neovascular membrane. And in the trabecular meshwork, there will be the clogging will block the trabecular meshwork. In that there will be trabecular glaucoma, which is a lens-induced glaucoma, which is blocked. The angle trabecular meshwork is blocked by the lens proteins and the macrophages, and the pigmented glaucoma, where the clogging up of trabecular meshwork is by the pigment particles. Glaucoma, where the trabecular blockage is by exfoliative material. And here the hemolytic glaucoma, the ghost cell glaucoma, the hemosiderotic glaucoma are the glaucoma which are associated with intraocular hemorrhages, where the trabecular meshwork is blocked by the macrophages with lysed RBC, and the Kakeler cells, which are the degenerated red cells, and the sclerotic in the trabecular meshwork. The acute inflammatory glaucoma is an secondary open angle glaucoma where the trabecular meshwork is blocked with the inflammatory in the exudates. And there is a post-trabecular elevated pixillary venous vascular. Now the angle closer glaucoma. Angle closer glaucoma. Here the intraocular pressure remains constantly raised and there is similar visual features and changes which are in primary open angle glaucoma, and in the secondary angle closer glaucoma initially there is a relative pupillary block where the apposition of pupillary margin against the lens surface in a mid-dial pupil occurs. Due to this, the pressure in the posterior chamber where the
You're not audible. Okay, I think we have a network problem here. So, Navya, can you start with your next talk? Can you start sharing?
Yes,
your
ma'am.
screen? Yeah, please.
Am I audible, ma'am?
Yes, yes. Please go ahead.
Good morning, all. Today, my topic is about primary open-angle glaucoma. Mainly deals with the etiopathogenesis and the clinical features. It is also known as chronic simple glaucoma of adult onset, characterized by slow progressive rise intraocular pressure, is greater than 21 mm Hg, and open normal anterior chamber angle, and characteristic optic disc cupping, and along with specific visual field defects. Next, etiopathogenesis, the predisposing risk factors are intraocular pressure. It's the most important risk factor. Next, heredity, family history, that having polygenic inheritance. 2 dozen loci have been identified for open angle glaucoma, out of which only 3 have been coloned. The myocilin C, optinurin, WD repeat domain 36. Age, the risk increases with increasing age. The common among fifth and seventh decades race. They are more common and severe in black people, and myopes are more predisposed than the normals. So then central corneal thickness, the thinner CCT is an independent risk factor, and diabetes and smoking increases risk for open angle glaucoma. High blood pressure, they do not cause rise in IOP, but the prevalence is more common in hypertensive than the normotensives. Same as that thyrotoxicosis. Prevalence is more common in Graves' ophthalmic diseases. Next, pathogenesis of rise in IOP. Rise in intraocular pressure occurs due to decrease in aqueous flow facility. The failure of aqueous flow pump mechanism causes due to trabecular meshwork stiffening and apposition of Slim's canal. Such changes are caused by age related, such as thickening and sclerosis of trabecular meshwork with fatty collagen tissue deposition, and there's a trabecular space narrowing, and amorphous material deposition of amorphous material deposition, and there is a collapse of Slim's canal. There is an involvement of immunogenic mechanism. Um, uh, there's an increase in gamma globulins and plasma cells in trabecular meshwork. They are seen in immunohistochemistry, which gives that there is an involvement of immunogenic mechanism. And while coming to clinical features, the symptoms, asymptomatic, disease is insidious and usually asymptomatic unless there is a significant loss of vision. Normal non-specific symptoms are headache and eye ache with mild intensity, difficulty in reading and close work due to increasing accommodative failure. The increasing accommodative failure is due to the constant pressure of ciliary muscle due to rise because of rise in intraocular pressure, and delayed dark adaptation, scotoma. There's a defect in visual field. Loss of vision blindness are seen in untreated cases. Next, signs. Anterior segment signs. Ocular examination, it includes slit lamp biomicroscopy. In late stages, pupil reflex becomes sluggish. There's a hazy cornea seen and low central corneal thickness. Intraocular pressure changes, they are not permanently increased, but it shows a diurnal variation. The morning rise of IOP is seen in 20% cases, but its afternoon rise is seen in 25% cases. The most common are the biphasic rise, which is seen in 55% of cases. When there is a rise of 5 mm in IOP, those are suspicious cases, but the diagnostic of glaucoma, when there is a constant 8 mm rise in IOP is seen, it is known as diagnostic for glaucoma. In later stages, the IOP ranges between 30 to 45 mm of Hg. The normal ranges from 10 to 21 mm of Hg. And glaucomatous optic nerve head changes in fundus examination when done in stereoscopic view. There contact and non-contact lenses are used, but non-contact lenses are more convenient. Next, Heidelberg retinal tomography is the most accurate and sensitive for recording and documentation techniques. Next, glaucomatous changes. There are early changes, advanced changes, and glaucomatous atrophy. Well, coming to the early changes, there's a vertical oval cup is seen due to sensitive loss of neural rim in the superior and inferior poles. Asymmetry of cups is seen. Large cup is seen, and splinter hemorrhages are seen along the ridges, the optic disc margin. Next, pallor areas are seen on the disc. Atrophy of retinal nerve fibers are seen. The defect, it appears as a wedge-shaped dark areas arising from the optic nerve head. And when coming to advanced changes, there's a thinning of neural rim is seen, which appears as a concentric shadow adjacent to disc margin. Normally, the thickest to thinnest parts of neural retinal rim are inferior, superior, and nasal temporal. Any variation from these helps to detect glaucoma, and superior or inferior notching of the rim is seen as pathognomic, and pulsating of retinal arterioles are seen. There's a nasalization of vessels, which is known as bionating sign. The edges, the blood vessels, when the edges overhang, the courses of vessels as they climb the sides of the cup is hidden, and laminar dot sign is seen, whereas it becomes the pores in the lamina cribrosa become slit shaped and are visible up to the margin of the disc. Next, glaucomatous optic atrophy. In this, all the neural tissue of the disc is destroyed, and optic nerve appears white, which is usually yellow in color and is deeply excavated. Next, visual field defects. It is only seen when 40% of axons are damaged. Anatomical basis of field defects, the distribution and arrangement of fibers is seen. In distribution, fibers coming from the nasal half of retina comes to optic disc as superior radiating fibers and the inferior radiating fibers. From macular area, they come horizontally as macular bundle. From temporal area, they arch above and below the macula and papillomacular bundle as superior arcuating fibers and inferior arcuating fibers. Superior and inferior arcuating fibers are most sensitive for damage, where macular fibers are more resistant. Next, nomenclature of glaucomatous field defects. This is Jerum's area. It is a central 10 to 20 degrees of the visual field from the fixation point. The natural history of the progressive glaucomatous field loss more or less takes the following sequence. Firstly, isopter contraction. There's a mild generalized contraction of central and peripheral field is seen. It is the earliest visual field defect field due to inward curling of 30 degrees central field is seen. The next is a small wing-shaped paracentral scotoma. It is an earliest clinical significant changes. It appears either above or below the Jerum's area. Next, sedal scotoma. With passage of time, paracentral scotoma joins blind spot to form sickle-shaped scotoma known as scleral scotoma. Next, arcuate scotoma. It is formed by extension of sedal scotoma in an area either above or below the fixation point to reach the horizontal line. Double arcuate scotoma, it develops when two arcuate joins together. The next stage is Royen's central nasal step. It is created when two arcuate scotomas run in different arc and meets to form a sharp right angle defect at horizontal medium. Next, peripheral field defects. It is due to the unequal contraction of peripheral isopter. The advanced glaucomatous field defects, the visual field loss gradually, centrally as well as peripherally. Only tubular vision and temporal islands are left. The temporal islands are most resistant when compared to the tubular vision. Next, the investigation tonometry is done. Central corneal thickness, when there's a less than 555 mm of 555 microns of CCT, it is an independent risk factor for conversion of ocular hypertension to open angle glaucoma. Then diurnal variation tests are done. Gonioscopic, it reveals a wide open angle of anterior chamber. Next, slit clamp examination are done. Perimetry, it is to detect the visual field defects, and provocative tests are done. Diagnosis for primary open angle glaucoma, it is characterized by raised IOP with a definitive glaucomatous optic disc cupping and visual field defects. Next, ocular hypertension. There's a constant rise of IOP more than 21 mm of Hg with no optic disc and visual field changes. Normal tension glaucoma. It is diagnosed when glaucomatous disc cupping with or with or with or without field changes. But the IOP remains below 21 mm of Hg. Thank you.
Navya,
Yes, ma'am.
so with what instrument will you be measuring the central corneal thickness?
And
What
Rennie's
what is the instrument called as?
Rennie's pen.
Anyone who can answer, even via chat?
Ma'am, pachymeter, ma'am.
Yeah, so it's a pachymeter, okay? So you can measure central corneal thickness, you can use a pachymeter. And so what is the, and with what are you measuring, with what instrument are you seeing the angle of the anterior chamber?
Angle of anterior chamber.
What are you seeing it with in the outpatient department? How will you examine the angle of anterior chamber with what instrument? What is that? Your colleague spoke about it in the earlier slide.
Copies lens.
What is that lens?
Copies lens.
What is the procedure known as?
Gonioscopic examination.
Exactly, it's gonioscopic examination. Now, what is the gold standard measurement for intraocular pressure? What is that instrument known as?
Ma'am?
What are the two types of tonometry you know of?
Ma'am, your voice is not clear, ma'am.
What are the types of tonometry you know?
Tonometry,
Yeah.
Tonometry. Applantation tonometry and indentation tonometry.
It's not applantation, it is applanation, okay?
Yes, ma'am.
It is Goldman's appellation tonometer, okay?
Okay.
And you spoke about optic atrophy, right?
Yes, ma'am.
So what are the other types of optic atrophy you know of? Navya?
Yes, ma'am. Primary optic atrophy and secondary optic atrophy.
And there is also, if I believe, there is also one more. What is the optic atrophy you see in retinitis pigmentosa? Anyone
Don't know, ma'am.
who can answer?
Ma'am, consecutive optic atrophy.
Yeah, somebody has answered consecutive. They are right. So Navya, you spoke about visual field defects extensively, right? So again, the same question, with what instrument will be looking for, in what instrument can you test? What is it known as?
Ma'am,
You spoke about visual field testing. What is that procedure known as? It is known as perimetry, okay?
okay, ma'am.
Okay. You most
Okay.
commonly, we have a couple of answers. They are absolutely right. It's perimetry. So you use it usually nowadays we test it using a visual field analyzer, and so it becomes an automated perimetry. Okay. So we assess it usually using a visual field analyzer. So, okay, thank you, Navya. Ashwini Dutt, are you there? Is Ashwini Dutt there? You're there. Ashwini Dutt, is your net all right now? Ashwini Dutt, if your net is not all right, then maybe you'll present again first thing in the morning tomorrow. So tomorrow morning, again, we'll be starting with congenital glaucoma and then again treatment. And we'll be discussing again treatment of POAG, and then we'll move on. So tomorrow, the next three speakers, I mean, including Ashwini Dutt, and the next two speakers, please be ready. Someone is very eager to know about the second internal results. They've been messaging. So we'll let you know. Don't worry about it. Okay. So we'll ask sir and then we'll let you know about the results. Okay. So thank you. So tomorrow we'll be discussing the further topics. Thank you till then. Okay.
Mira, me mudé de una vez.